Well, hi everybody, and welcome to IPDLN 2020. My name's Stuart Kinner. I'm the head of the Justice Health Unit at the University of Melbourne, and I'll be chairing this session. This is the session on addiction. So the format for today is that we'll have 4 speakers, each speaking for 10 minutes. And at the end of that, we'll have, if everyone sticks pretty much to time, 20 minutes for Q&A at the end. So if you do have comments or questions during any of the sessions, please feel free to type those into the Q&A function in the portal, and we'll get to all of those hopefully at the end of the presentations. So with no further ado, I'd like to introduce our first speaker for this session, who is Lindsay Pearce. Lindsay Pearce is a research fellow with the Justice Health Unit at the University of Melbourne in the School of Population and Global Health. She worked with me as a great colleague. Lindsay completed her Master of Public Health degree at the University of British Columbia and an undergraduate degree in Health Sciences at Simon Fraser University in Vancouver, Canada. Lindsay's research and work is focused on the health and healthcare experiences of vulnerable populations, including people who use drugs, people living with HIV and hepatitis C, and incarcerated populations. Lindsay, over to you.
I'm so sorry, I forgot to unmute myself. Sorry about that. So as Stuart mentioned, I'm Lindsay Pearce. I work with the Justice Health Unit at the University of Melbourne. And today I'm presenting on a retrospective cohort study that was examining opioid agonist treatment and risk of mortality during an opioid overdose public health emergency. And this was work that I conducted in my previous role at the Health Economic Research Unit, which is part of the British Columbia Centre for Excellence in HIV and AIDS in Vancouver, Canada. So before I begin, it's important for me to declare that this work was conducted on the unceded territories of the Coast Salish people, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations in British Columbia. And I also acknowledge that I'm speaking today from the land of the Wurundjeri people in Melbourne, Australia, and I pay respects to their elders past, present, and emerging. And I'd also just like to acknowledge all the wonderful contributions of the co-authors on this work that not only helped to put these slides together, but we're also co-authors in a peer-reviewed manuscript that was recently published in the BMJ that more details this analysis. So you're welcome to check that out. So now that we can dive in, I just want to provide some background on the context in British Columbia during the study period. So this is a graph of the number of illicit drug overdose deaths and the death rate per 100,000 population in British Columbia beginning in 1992. And as you can see, around 2014 and 2015, there was a very stark increase in the number of illicit drug overdose deaths in the province. And not coincidentally, this coincided with the rapid increase in the number of fentanyl detected illicit drug overdose deaths. So in 2012, about 4% of illicit drug overdose deaths contained fentanyl, and this rose all the way up to 87% in 2018. And for those of you who are not as familiar with fentanyl, as it is quite common in British Columbia and across North America, fentanyl is a very potent synthetic opioid that is very cheap to develop and really easy to distribute globally. And it's up to 10,000 times more potent than morphine, so it's quite deadly. And following this rise, the provincial health officer in British Columbia declared a public health emergency. And again, not similar to BC, but also similar across North America, one of the key strategies to address this increased risk of mortality was strategies to increase access to opioid agonist treatment. And we know from quite a large amount of previous research, as well as a recent systematic review and meta-analysis by Sordo and colleagues in 2017, that retention on OAT is associated with a reduced risk of mortality. However, despite this benefit, periods after OAT are characterized by very high mortality risk, particularly in the first week after stopping treatment. And this is quite problematic because people tend to cycle on and off of opioid agonist treatment. And despite this relationship, at the point of this study, this relationship had not yet been examined within the fentanyl era or in the context of high fentanyl prevalence. In British Columbia, at the time of the study, the main formulations of opioid agonist treatment that were available were methadone, buprenorphine, naloxone, slow-release oral morphine, and injectable OAT. In this analysis, we'll primarily be comparing methadone and buprenorphine naloxone, simply because we just didn't have a large sample size of folks on slow-release oral morphine or injectable OAT because they were available quite a bit later in the study period. So to do so, we linked 4 provincial health and administrative data sets from 1996 to 2018 that captured drug dispensations, records of hospitalizations, deaths and their underlying causes, as well as physician billing records that were used to determine comorbidities at the time of first OAT dispensation. And we identified study participants based on the presence of at least one OAT dispensation in the PharmaNet database, which contains the drug dispensations. So we included all OAT recipients during the study period. We then classified deaths as on OAT if they occurred basically in two scenarios. First, if the death occurred on a date in which OAT was dispensed or when it was filled in the case of take-home doses, or if a death occurred in hospital among people on OAT prior to admission. And this is simply because we didn't have any drug dispensation records during hospitalizations and best practices that these folks would continue treatment while in hospital. We then calculated crew mortality rates and age and sex standardized mortality ratios and compared them by periods on OAT versus after stopping OAT, by time since starting and stopping OAT, and across key dates of the public health emergency. So in total, we identified just over 55,000 OAT recipients during the study period, of which 2/3 were male. We also observed quite high rates of other substance use disorders, high rates of mental diagnoses, as well as chronic pain. And approximately 17% of the study population of OAT recipients died during follow-up. And from a total of just over 400,000 person-years of follow-up after OUD diagnosis, we observed a low risk of all-cause mortality and drug-related mortality on OAT versus after stopping OAT. And I've just highlighted in the table below those key results. So you can see that the all-cause standardized mortality ratio was just over twice as high for those after stopping OAT compared to those on OAT. And the drug-related crude mortality rate was just about 4 times higher off of OAT compared to on OAT. When we looked at mortality risk by time since stopping and starting OAT, we weren't surprised to find that the highest risk of mortality was in that first week after stopping OAT, and that was approximately 3 times higher among methadone compared to buprenorphine. And just as a comparison to that second week after stopping OAT, it was lower, but still quite a bit higher, and quite high, around 21.5 for methadone and 18.8 for buprenorphine naloxone. And again, just as a comparison, even in the second week was still quite a bit higher than the first week after starting OAT. We also looked at mortality risk over time, and what we saw was quite interesting. So we saw that the risk of mortality off of OAT increased over time as fentanyl became more prevalent in the illicit drug supply between 2010 and 2018. But surprisingly, despite this increase in fentanyl in the illicit drug supply, we did not observe any increases in the risk of mortality on OAT. And in fact, we saw a very slight decrease, though, of course, those confidence intervals are overlapping. And then we also looked at the relative risk of mortality off of OAT versus on OAT. So just looking here at the adjusted, kind of picking out some results, the risk of mortality off of OAT, or the relative risk of mortality off of OAT compared to on OAT was 2 times higher before the introduction of fentanyl into the illicit drug supply. And then this increased towards the end of the study period to 3.4 times higher, which was about a 65% increase in risk. And of course, with any study, there are limitations that are worth noting. Firstly, there are small numbers of deaths in person time observed on buprenorphine naloxone because it was relatively new in British Columbia, which sometimes limited our comparisons over time and compared to methadone, as we had wider confidence intervals and less precision. We also had some missing cause of death information. We had 57% of deaths in 2018 and 13% of deaths in 2017 were still under investigation at the time of the study, which limited our interpretations of cause-specific mortality. We also did not capture health services that were received and any deaths occurring outside of British Columbia. So if people were crossing borders, we may have misclassified them or not captured their deaths, for example, if they'd gone to a different province. But we did expect this to be quite negligible over the study period. And finally, of course, this is largely a descriptive study and should be interpreted as such. Participants were not randomized to medication type or status. Therefore, any underlying differences may exist in patient populations that may have influenced results. However, as we demonstrated when we controlled for baseline patient characteristics, we did not see major departures from our unadjusted numbers, and this was also similar in Sordo's meta-analysis. So that's promising, but then again, something that should be examined in the future, particularly with time-varying confounders. And finally, the study concluded in a novel finding to arise from this was that the protective effect of OAT on mortality strengthened as fentanyl and other synthetic opioids became more prevalent in the illicit drug supply in British Columbia. However, we still did observe very large increases in the risk of mortality immediately after stopping OAT. Therefore, given these risks, I think a key implication to come of that is that interventions that are being rolled out to improve access, which are quite common in BC as well as other jurisdictions experiencing increased risks of mortality due to fentanyl and other reasons, they need to be implemented alongside other interventions aimed at improving retention. And we need to do this in order to maximize the public health and individual benefits of this treatment. And finally, I'd just like to acknowledge that this data linkage project is part of a much broader response to the public health emergency. And I think we'll hear a bit more about that in other sessions, other presentations in this session. But it was a really important connection for us to have in working with the British Columbia Ministry of Health in terms of driving these findings towards helping to inform evaluation and adaptation of the response and providing intel into what's happening on the ground. So I think it's a good example of where partnership and data linkage can really come together to improve public health. And I think that's all I have. So thanks so much. And I look forward to your questions. And hopefully I was under 10 minutes, but Stuart didn't cut me off. So that's good.
Thanks, Lindsay. A great presentation and right on time. Just a reminder to folks listening in that if you do have any comments or questions, please put those in the Q&A and we'll get to those after the full presentations. Our second presenter today is Claire Keane, also from the Justice Health Unit at the University of Melbourne. We've got a fantastic bunch of people in our group. A real pleasure to introduce Claire, who works as a research assistant and is unit manager for the Justice Health Unit in the Melbourne School of Population and Global Health. In that role, Claire manages and conducts analysis for multiple projects examining health outcomes and health service utilisation for people who've had contact with the criminal justice system. Claire, over to you.
Thanks, Stuart. As Stuart mentioned, I'm Claire and I'm a research assistant in the Justice Health Unit. And today I'm presenting some research that I conducted in collaboration with the BC Centre for Disease Control in British Columbia, Canada. So I think we're a very Canada-focused session today, so that's very exciting. And this research is looking at time-varying vulnerability to non-fatal overdose using a self-controlled design. So as Lindsay has mentioned so clearly, overdose is a big public health crisis, and in BC, in Canada in general, and across the globe, we're seeing increasing rates of fatal overdose. Globally, there's over 100,000 overdose deaths annually, and the overdose rate is particularly high in North America. In British Columbia particularly, there's really high rates of overdose. And while overdose mortality rates decreased in 2019, we're seeing increased rates again this year as COVID makes management and response a lot more difficult. So there's a continued need to focus on overdose prevention and response. And one important factor to consider is that the risk of overdose is not constant. As Lindsay pointed out, there are lots of interventions we can have, and there's lots of periods of time when the risk is altered. It's either increased or decreased. So for example, after release from prison is a period of time where the risk of fatal overdose is incredibly increased. So drug-related deaths of the first 2 weeks greatly dwarfs the number of drug-related deaths that occurs in the weeks following that. And similarly, just as Lindsay mentioned, when you're on OAT or treatment, the rate of overdose is greatly reduced compared to that when you're off treatment. However, while these two periods have been examined in quite a bit of detail in relation to fatal overdose, there's been almost no research on non-fatal overdose, which is incredibly a lot more common and can cause lifelong health concerns, and is also a predictor of subsequent fatal overdose. So it's a really important moment for prevention and a really important moment for response. There's very little research on non-fatal overdose during these periods, and it's a bit conflicting. So there's unclear research whether the same patterns exist for non-fatal overdose as do for fatal overdose. And there's also a lot of other periods of time that just haven't really been examined, such as following discharge from hospital, where there's been about one study that suggests maybe for fatal overdose, the period of release from hospital is one that is maybe of higher risk, and also for medications such as opioids, benzodiazepines, and antipsychotics, which haven't been really examined in this way. So the aim of my study was to look at these time periods of interest and their association with non-fatal overdose using a self-controlled design. So I used a 20% random sample of residents of British Columbia, and this is a part of the BC overdose cohort, and it was linked to a broad range of health and socio-economic databases, including incarceration, ambulance, emergency department, hospital records, coroners, death records. For my purposes, the cohort was limited to those who had a non-fatal overdose during follow-up, so between 2015 and 2017. Overdose was ascertained through many, many data sets, which increases ascertainment, as we know that about 50% of overdoses don't result in medical care. So by linking all of these in, we're able to ascertain a much greater number of overdoses. And we use a self-controlled design. So this is conceptually similar to a cohort study in that we're using all people's follow-up period time, except it's limited to cases only. And it uses people as their own control. So we use a conditional Poisson regression to control for individual level static confounders. And basically it lets us ask the question, why did this event happen now? Rather than why did this event happen to this person? So it's really useful, these time-dependent events. It hasn't been used extensively in overdose research previously. So in order to create the analysis, we broke people's follow-up time into periods of interest for each of these events. So looking at the periods of initiation and discontinuation of these medications, as well as times after discharge from hospital and emergency department care and after release from prison. So in the study, we had about just over 4,000 people who experienced a non-fatal overdose. And the rates of this were, the proportion of people who experienced our exposures of interest were a lot higher than in the general population. So for example, 25% of people who overdosed were incarcerated during this follow-up period, compared to less than 1% of the total random sample, and 41% was applied an antipsychotic, compared with 4% of the random sample. So we have a huge number of people experiencing these exposures, which just to start with is suggesting that this group is very unique in experiencing a lot of complex medical conditions, a lot of periods of transition and discontinuity. So now I'm just going to take you through what some of the results were for this study. So this is looking at incarceration, and we're comparing all our results to this unexposed periods, which are times when people aren't in prison, and it's not including the post-release period. So what we see is similar to what we've seen in previous research. It's got much lower rate of death while people are in prison, and we've got this higher rate in the first 2 weeks after release. So this is consistent with previous analysis that's looked at fatal overdose. What we have seen here that we haven't seen in previous analysis is that the day of admission was also high risk. It's unclear to us at this time if anyone has really looked at this before, and this was reduced in sensitivity analyses where we changed the definition of overdose. So it's unclear what this connection might be, but definitely something that is worth further investigation. For medical care, we saw a small increase in the rate of overdose in the time following release from discharge from hospitalization. but very little difference after emergency care. And this might be a combination of the emergency care doesn't really create too much of a discontinuity, as you might not be there for very long, and also that a lot of people are transitioning from emergency care, if it is similar, into hospital. So their follow-up, their post-discharge is then while the time when they're in hospital. But another thing to remember is this is hospitalization for any reason. So this is hospitalization not just for an overdose, but for any reason. And we're seeing an increase in rate of overdose after release, which is suggesting that it is something to do with transition periods that needs to be, people really need to have a good level of support. Similarly, just as Lindsay was talking about, when we looked at OAT, so opioid agonist therapy, we saw a decrease for the period of time that people were on OAT, and then a return to baseline or unexposed levels once people are off. There wasn't, like we're seeing in previous research on fatal overdose, increase in risk after release. It's unclear why we might not be seeing that. One reason might be that it's actually a particularly dangerous period and there's a bit of survivor bias because we're only including non-fatal events. So it might be that events in this period are more fatal, or it could be that we just didn't have enough events and we're only looking at first events in this population. And what we also saw with opioids is that these is opioids for chronic pain, is that there was an increased rate while people were supplied overdose, which suggests that prescription opioids are also playing a part in this occurrence. But what was more worrying was the much larger increased rate for when people were prescribed benzodiazepines, particularly the day of supply, and then this continued throughout the entire period of use. So it's well known that benzodiazepines are a common co-occurring drug in opioid overdose, but this reinforces the evidence that people prescribed benzodiazepines, particularly if they have a history of using opioids or are co-prescribed opioids, need to be a group that is a lot of attention is put on. And the last finding that we found that was quite interesting was what we found with antipsychotics was that it was the period post-discontinuation where there was an increased rate of overdose. This hasn't really been examined previously, but there has been some research in that discontinuation can be a really difficult time for people who are using antipsychotics, and can be particularly if people discontinue abruptly. So it may be that we're seeing that this is a moment of complexity and of underlying medical health issues that are contributing to people's rate of overdose. So just to briefly have some conclusions, what we see through this is there are distinct time periods where the risk of overdose is altered. And that these represent moments where prevention and responses are urgently required, particularly when we know that funding is limited. These moments represent moments where we can have a particularly large effect. And it's important to note too that there's periods of time which are protective as well. As Lindsay mentioned, the continued use of OAT is a really protective point for people using, for people at risk of overdose. So ensuring that we allow access and increase access to those services is really important. And this was just very preliminary work, so it's the combination of using a self-controlled design and linked data provides unique opportunities for exploring these sort of time-varying risks in more detail in the future. I just want to have thanks to my research team who were incredibly helpful in putting this work together, and thank you.
Thanks very much, Claire. That was a great presentation and a really good compliment to Lindsay's, and again, bang on time. So thank you for that. Our third speaker today is Chloe Xavier, who's an epidemiologist in the provincial overdose cohort at the BC Centre for Disease Control. The provincial overdose cohort links, as we've heard, administrative health data to identify drug-related overdose events to inform provincial, regional and local overdose response activities. Chloe has a Master's of Public Health and Epidemiology from the University of Toronto and has experience in community engagement, health and equity research and data collection for hard to reach populations. Chloe, over to you.
Thank you, Stuart. So today I will be presenting, and this is actually really well timed because Claire just presented an analysis using the provincial overdose cohort. So it's nice that it kind of segues into kind of the description of the provincial overdose cohort. So that's what I'll be presenting to everyone today. I just want to acknowledge my team, Dr. Amanda Slonwhite, Winshigan, Bin Zhao, Roshni, and Anna, who have helped me pull together this presentation. And I'd also like to acknowledge that I'm from the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And an important part of doing the work here is, locating myself as a settler on these territories, as an uninvited visitor, and meaning that I tread as lightly as possible while I do this work. So without further ado, I'm not going to go through this much more. I think there's been a good intro of the overdose crisis here in BC and then also in Canada. This slide is just showing the rate of paramedic attended overdose events between 2015 to 2020, and then also the rate of illicit drug overdose deaths in the province of British Columbia. So people have said it's been increasing relatively steadily, and we've seen a really big spike since the declaration of the pandemic. So here we can see we've recorded the highest number of overdose deaths in the province to date in the past few months. So the provincial overdose cohort was created in response to sorry, I'm just gonna minimize this so I can see my slides. There we go. So in response to the provincial health officer's declaration of the public health emergency, this declaration ensured that there would be timely access to the required data to carry out overdose emergency activities and to support evidence-based decision-making. So the BC Provincial Overdose Cohort is a set of linked administrative sets which identify drug-related overdose events, and this includes a variety of different administrative health data, including physician records, emergency department visits, hospitalizations, prescription medication, and other. The governance of the cohort is unique and interesting, is we have partnerships across the different health authorities in the province with the Ministry of Health, the Ministry of Mental Health and Addictions, the First Nations Health Authority, and other stakeholders such as the BC Centre on Substance Use. This governance includes a shared data governance model, and that ensures that we have inclusion of different partners in the development of priorities, as well as the selection of research questions, etc., throughout the work that's conducted using the cohort. Another important part of the cohort is Indigenous data governance. So the First Nations Health Authority leads all work related to First Nations people. So the cohort has been linked to the First Nations client file, and it is FNHA, or the First Nations Health Authority, that has access to that data. No one at the BC CDC has access to that data, and it really ensures that that work is led by FNHA, and that it supports the OCAP principles and the self-determination of Indigenous people. Another piece of the cohort is to try include community in the work that's being conducted. So a key piece is the involvement of persons with living and lived experience in substance use, and this includes throughout all the process. So priority setting, research questions, the interpretation and dissemination of findings from the provincial overdose cohort. And this just ensures that there's a joint knowledge development, knowledge sharing, and capacity building across the different sectors and organizations, and capacity building within community members and people with lived and living experience, as they are the experts in this work. The bottom here is just kind of an example of how we've engaged, or how people with lived and living experience are engaged in the work through the priority setting exercise that happens annually. So what kind of data do we have? How is the cohort built? So the Ministry of Health performs individual or person level data linkage using administrative health history data. Once that data has been linked and de-identified, it is sent to the BC Centre for Disease Control, and our team cleans the data and then is in charge of the analyses. And this is separate from the First Nations client file work, which is sent to them on their own separate file transfer. So currently the provincial overdose cohort contains records from January 1st, 2015 to December 31st, 2018. And as Claire has said, it includes many different linked data sets, including hospitalizations, death records, income and social assistance records, diagnosis of mental health or physical health conditions. So this is taken through hospitalization records, primary care visits, etc. We have emergency department records, provincial incarceration records. We do not have federal level information, so so that information is not included. And then a variety of other appended data sets. So this right here is showing, I think actually Claire had a nicer diagram. I was looking at it and I was like, oh, I should have included that in my presentation. But that shows how we identify overdose in the data set. We identify overdose through non-fatal or fatal records. Non-fatal overdose is identified in paramedic records, drug poisoning information records, emergency department visits, primary care, and then so there's an algorithm that selects non-fatal overdose using that, and then we also can identify fatal overdose using the provincial coroner service records, as well as biostatistics death and a drug-related overdose algorithm that also identifies death. From there, we can examine overdose kind of in three ways. So I can examine overdose at the encounter level, so a single visit to a primary care physician, for example, in relation to overdose, that would be an encounter level information. Then we can look at overdose at an episode level, so multiple encounters, such as someone is transferred to the hospital using or by a paramedic and then is hospitalized and then is discharged. That would be grouped together as a single overdose episode, as they were all related encounters. And then we can also examine overdose at a person level. So the cohort really allows for different ways of examining overdose depending on the type of question. The cohort, an important part of the cohort is, of course, providing access to this data so that it may inform the overdose response happening across the province. As I mentioned, or I may not have mentioned, but working groups is one big piece of the work that we do. So the BC CDC leads priorities and research questions that are outlined by different stakeholders and people with lived and living experience. And these projects are conducted using working groups where we pull together different experts in the field. Another way that the provincial overdose cohort is used by health authorities. So since this is pulled together by a public health order, health authorities, of course, have full access to the cohort as it is a shared data source. So the projects and conduct specific population analyses. The First Nations Health Authority is an example of this. And then the third way is through Population Data BC, which was recently pulled together to provide external researchers in Canada access to the cohort, submit a proposal for a project, and if they align with provincial priorities, they can gain data access and conduct this analysis in collaboration with the data stewards. So there's some strengths and limitations to the cohort, of course. The biggest piece is that it's very comprehensive. It includes both non-fatal and fatal overdose events identified through a robust case definition that was developed by multiple stakeholders and experts in the field over a 2-year period. It includes primary, secondary, and tertiary level healthcare data. So we have overdose event information from 2015 to 2018, but healthcare data is available from 2010 to 2018 currently. So we do have a long healthcare history information. And then we can also use the cohort to examine social determinants of health and how they impact risk of overdose or just overdose in general, intersections such as social assistance or income, geography, rural versus urban morbidities, incarceration, etc. And another part of the cohort is that it does include a 20% random population sample, which facilitates. And then my last slide, just some limitations to the cohort. It is administrative health data, so it doesn't capture all overdoses happening in the province. So it underestimates the number of overdose events, particularly those happening in the community where people do not access healthcare. It cannot be used for surveillance. The cohort is usually about a year delayed, so it currently goes up to 2018, and we are currently almost getting ready to get the 2019-2020 data, so it is a bit behind. And then because it has been de-identified, it cannot be linked to other data sets. And that's it. Thank you.
Thanks very much, Chloe. It's fantastic to get a more detailed overview of the cohort and the governance that surrounds it. It's evidently been a very large undertaking. So with no further ado, we'll move on to our fourth and final presenter, Dr. Paul Kurdyak. Paul is the Director of Health Outcomes and Performance Evaluation at the Institute for Mental Health Policy Research, Medical Director of Performance Improvement at the Centre for Addictions and Mental Health, and a Senior Core Scientist and the Lead Mental Health and Addiction Research Program at ICES. His research focuses on clinical epidemiology and health service utilisation, providing a better understanding of the determinants of and barriers to treatment for mental illnesses, exploring the relationship between chronic medical and mental illnesses, and developing methodological expertise in observational research design for mental health epidemiology. Paul, over to you.
Yeah, sorry, Stuart, that was an unnecessary mouthful. I am here in Toronto, and you just heard a bunch of people from both Australia and BC talking about BC data. I'm going to be talking about something a little bit different, which is leveraging a novel bit of data that we link to our ICES data holdings to understand whether or not people who should get care to addictions treatment in the community services actually do. And I have on my screen, in addition to me, the team that worked on this, Jenny Gatov's the epidemiologist, Hannah was our analyst, Francesco and Daniel and Rachel were all part of the community business intelligence, which I'll tell you about. Not much to say in terms of conflict of interest, and just supported by our Ministry of Health and by Reconnects, which oversees the data repository I'll describe in a second. So I work in a psychiatric emergency department, and much of our business includes individuals with alcohol and other substance-related disorders. They often come seeking withdrawal management or management for acute intoxication. And then we typically provide them with information about referrals to community settings. And the question I've always had as a clinician is whether or not they go. And so that's always been a bit of a black box to me clinically, and it's always been a bit of a black box to us at ICES. Because we've never had, except for what coding for substance-related disorders we have in sort of the physician, emergency departments, hospitalization, and some of our drug data, including sort of opioid agonist treatment data. That's sort of proxy measures for actually whether people are receiving treatment for substance-related disorders in community settings where the bulk of it occurs in Ontario. So CBI refers to community business intelligence, and it is a very small set of variables, about 9 or 10, and they just include patient identifiers and a start date and a stop date for various programs in the Toronto region. And they are sort of broken down into 3 types: community support services, which are mostly for the elderly; community mental health, which would map onto things that would be familiar to you, like assertive community treatment and case management and crisis support services. And then there's community addictions, which is 16% of all of the CBI records. And what I'm showing you here is the linkage rate, and the dark green is deterministic, but the main point is that for the purposes of our addictions work, we had a pretty, like 91%, given the type of clientele that are represented in the addiction services, is a great linkage rate for this type of data. So within our eMERGE database, we took individuals older, 16 years of age and older, and I won't go into the details, but we ultimately got down to a group of individuals who had 2 or more emergency department visits in a year for substance-related disorders. And the idea behind that was to look for individuals who had, one-off ED visits we see all the time, and particularly, for example, we're right beside the University of Toronto, so we in the start of university, except for this year, we typically see university students overdoing it for the first time and needing a little bit of help, and we never see them again. So we wanted people who had more than one visit as a signal of need. And then our outcome was whether or not they actually accessed those community-based addictions treatment facilities or services within 1 year of their last ED visit. In the Toronto region. We had a bunch of covariates that we included, but really the main thing was, the main question was, among a population in need, are they accessing services? So here's the main point. So we boiled down to about, in that 1 year, there were 8,646 ED visits. And then from all those ED visits, there were 2,003 unique individuals who were 16 years of age or older and had more than 2 emergency department visits. And here's the main point, that of those 2,003 individuals who appeared to need community-based services, only 11% made it into those community-based addiction services. So just a little more than 1 in 10. And that to me is a really low hit rate. And the question for me is, who is accessing these services? Because that's quite a large number of individuals who are pretty severe in terms of their need. These are sort of unadjusted and risk-adjusted characteristics predicting whether or not you access services. So like with most services in general, those who lived in the highest income quintiles for neighborhood, like lived in wealthy neighborhoods, that was one of our strongest predictors of accessing services. Strangely, if you arrived for your substance-related emergency department visit by ambulance, that was a real marker of you not getting access to services, and we wonder whether that's a severity marker. And then, there aren't too many other predictors that are quite robust. So it's not clear what determines access. In a list of types of treatment, what was surprising to me was that about 60% of the services that this group actually made it to were residential services, and a relatively small subset made it to what you'd like to see, which is ongoing community-based care via case management or addictions treatment. These are just terms that map onto the services in the CBI data set. But I was quite surprised that even among that small population who did make it to treatment, very little were receiving ongoing care. They actually sort of made it into residential treatment, which is great, but you'd really like to see connection with case management and ongoing treatment being provided to these individuals. So some of the limitations. So our substance-related diagnoses in the emergency department are not validated and likely overly specific. We're probably missing a bunch of cases. Toronto residents may be accessing publicly funded addiction services outside of Toronto, and we have a lot of residential treatment that is in sort of in the country, so to speak, and away from the city. So if residential services is a preferential service for this population, then we're probably underestimating access a little bit. And then, especially for those with means, there are, in parallel to the publicly funded treatment facilities that are captured in the CBI data set, there is a parallel sort of private addiction treatment for those who are able to pay. So in conclusion, only 1 in 10 individuals who appear to need services by virtue of the frequency of their emergency department visits actually access the community-based addiction services. The services that they access are mostly residential treatment and less on the community-based and ongoing ambulatory treatment. And this is, to me, in addition to the really excellent work we saw earlier on mapping the opioid epidemic, I, as sort of the lead of our mental health and addictions treatment program, I feel like we know far little, at least in Ontario, really relatively little about how the ways in which people are accessing treatment and who's getting it and who isn't. And so this was our first foray. And now we have the same type of addiction treatment for the entire province. It's another data set linked, and we're starting to understand the nature of this. So we're looking forward to doing more of this kind of policy relevant work so that we can understand how better to align these community-based services, for which there's quite a bit of funding going towards it, so we can better align it with the population who most intensely needs it. And so this is our first foray, and we're quite excited about the opportunity to do more of this kind of work. And that's it.
Thanks very much, Paul. Some quite striking findings, and thank you for actually being under time. That was great work. We have about 18 minutes left for some discussion. I might start with some of the questions that have appeared in the Q&A, and for folks listening in, please feel free to keep typing questions in. We'll get to them as quickly as we can. There's a couple from Paul, but I might actually start with others. First, one from David Preen with a question for Lindsay. Have any new interventions to improve access to treatment been implemented as a result of your work and the wider program response? And if so, could you provide some details?
Just wanted to make sure I was off of mute that time. Yeah, I mean, unfortunately, I'm not too sure, as I've also left British Columbia, and I think it's also hard to tell because there were so many interventions being implemented around the time of the public health emergency. Increasing, access to new medications was one thing, but also they implemented new prescribing guidelines. They made it easier for physicians to prescribe to get that certification to do so. They opened many new clinics, particularly in Vancouver's downtown east side, for rapid access to opioid agonist treatment. So yeah, I think it's a really good question. So thanks, David, for asking that. I unfortunately don't have a very clear answer for you. I did read recently that there was a new program that was aimed at reducing stigma and discrimination in healthcare providers. And I think that was another piece of this that I didn't quite mention was the role of people with lived experience in this body of work, not just in the one coming from my old team, but also just they're very heavily involved in the response to the public health crisis in general. And the issues of stigma and discrimination in healthcare towards people who use drugs are very, very pervasive still. So I think, yeah, hopefully that's satisfying. I really hope that there are further changes to come. As we can see in British Columbia, the situation is not getting any better. So yeah, thanks.
Thanks, Lindsay. David, I hope that was helpful. Lindsay, one more question for you from Paul, our fourth presenter. Great presentation. Do you know what proportion of individuals on buprenorphine undergo tapering, which is more likely than with methadone, and the implications of bup tapering and risk of fentanyl overdose?
Again, I'm really not aware on that specifically, and I would feel uncomfortable to comment in case I didn't have accurate information. I would imagine it might be a bit better, just considering the kind of better safety profile of buprenorphine, having a longer duration of action and prolonged suppression of opioid withdrawal, as well as a reduction in cravings for other opioids and other drugs. I think it's an interesting question. I think something that I'll look into. Perhaps some of the other panelists have read any research on that recently.
Does anyone else care to comment? No? Okay. Okay, a couple of questions then for Claire. Claire, a question for you from Lauren Staples. Have you or others looked at hospitalizations specifically for mental health disorders?
No, as far as I know. So there's one wonderful paper by Stuart, what's Merrill's first?
Elizabeth.
Elizabeth, yeah. So Elizabeth Morrell, who has looked at hospital discharge and drug-related deaths following discharge from hospital, but that was the only piece of literature I could find. I think there's also a bit of work looking at discharge from psychiatric hospitals, which sort of does relate to that hospitalization for mental illnesses, though it obviously is a very acute pointy end of hospitalizations for mental illnesses, and that also found an increased risk, but we didn't break it down by type, as this is sort of very first level analysis, and that would definitely be something that would be interesting to look at.
And I wonder, Chloe, if you might want to add to that. I understand that the way in which the provincial overdose cohort's been established puts some parameters about the kinds of questions that it's appropriate to ask of those data.
Yes, that's correct. To my knowledge, there hasn't been any work with the overdose cohort looking at discharge from different healthcare institutions, but yeah, I know that is questions that have been asked by the community prioritization this year, so stay tuned maybe.
Thank you. And another question from Paul Kurdyak for Claire. Did you look at hospitalization length of stay as a predictor of overdose? A longer length of stay resulting in a greater likelihood of discontinuity as a possibility?
Also, no, I did not, but that would also be interesting. We have done the sort of that work with incarceration and found that it was either the quite short or the quite long that had higher rates. Short because there's no access to services, and long because you've got this greater discontinuity. So it's quite possible that there'll be a similar thing for hospitalizations. The analysis was slightly limited with looking at hospitalizations and ED because they were also a way of ascertaining the outcome. So we had to be really careful with the way that we modeled that to make sure that we weren't just modeling the fact that someone had an overdose and therefore ended up in hospital.
Any of the other panelists care to comment on that?
Yeah, the only thing, the reason I mention is because one of my graduate students is doing a study looking at people on continuous buprenorphine, and looked at, the question was not so much about length of stay or hospitalization, but rather if you have surgery, what is happening with pain management and the management of buprenorphine, because it's actually within the anesthesia community. It's a bit of an unknown question. And, you know, when we did the descriptive analysis, whether like day surgery, there was no issue, but if you got admitted, then all those issues about, you know, discontinuity through the hospitalization played out, and length of stay did, but this was a very sort of specific cohort. So I'm just wondering whether that our finding generalizes to the more broader community. But your findings about your thinking about the corrections, you know, generalizing to the hospitalization is interesting. I don't know whether the short hospitalization would be the same as the short corrections, because it wouldn't be necessarily disconnection to services. But I do think the longer the length of stay, that might confer risk.
Yeah, and I have to say, when I'm talking about short incarcerations, we're talking about less than 90 days, not a single day. So it's a very different sort of unit of time than we are with hospitalizations.
Indeed. A question from Lisa Sharwood for Paul. Thanks, Paul. Great work, and certainly regarding socioeconomic status indicators. We have seen similar in Australia, which likely speaks to advocacy, health literacy, etc. As you know, I'm interested whether you had indications within the data about the percent of referrals to community-based treatment outside the 11% who actually accessed.
Yeah, so it's a great question. And before I answer, I just want to say, like, I thoroughly enjoyed the presentations that preceded me. They were all just excellent work coming out of BC. So most of the addiction services in the community settings for the data that I brought into ICS to link are based on self-referral, and it's really based on the premise that, you know, for individuals to seek substance-related treatment, they need to be sort of motivated to do so, and I think that's generally right. But, you know, as a result of this, our findings, I've been thinking about, you know, there is this population, and I don't think it's unique to Ontario. I think there is this population of significant substance users who just sort of cycle in and out of the emergency department, and particularly people with alcohol use disorder who have a revolving door for withdrawal management. And I feel like that we need to be doing a better job of warm handovers and integrating addiction services, maybe not 24/7, but right beside the emergency department to really facilitate it. Because, you know, people are still like, the people that I manage their withdrawal, it's not like they're still a little adult. I mean, they've had a you know, major bender, and then they've had a bunch of Valium, and then and then we give them a paper and say, you know, go forth and navigate a system. That's you know, you can't expect good outcomes if those are the processes. So and you know, I mean, why is that adequate? And to me, it's just this is a disadvantaged population for whom it's always been quite easy to neglect, and it just isn't right. So I think these warm handovers and integration are really important. And we have a study coming out showing that the high stakes, these individuals, it's alcohol related disorders, but you know, 1 in 20 of the individuals with 2 or more alcohol related visits, the same kind of cohort, died within 1 year. If you go up to 5 or more visits in a year, 1 in 10 died within 1 year. And these people are 52 years old. So for sure, there's an opioid epidemic, and the cause and effect is so discrete, right? Like you consume fentanyl and you drop. But there's been an alcohol epidemic for decades, and we've largely neglected it. And so for me, I think that you know, in Ontario, I think there's a very legitimate reason to focus on opioids because it's a serious public health crisis. But I think we also need to think more broadly about the adequacy and the processes around addiction services beyond opioids, because this is a population who's dying not so immediately, but dying nonetheless as a result of really, really poor system development.
Thanks, Paul. And Lisa had a very quick follow-up question saying, would you have a variable within ED data sets regarding referrals made? Just going to this question about where people go or don't go.
Yeah, no, and that's precisely why we needed to link the data, because we don't have that information. So we've made, since the establishment of the mental health and addictions program at ICES, we've made a very concerted effort to bring in new types of data to sort of you know, fill in the black box that is the community sector in which there's tons of care going on, and we've really not got a good line of sight on.
Thanks, Paul. There's a number of people who've commented, great presentation, so well done to all the presenters. But another question from David Preen, this time for Paul. Apologies, I might have missed this, but is there possibly some form of reverse causation issue at play in that those unable or unwilling to access treatment services are more likely to be the ones who end up in ED due to poor management, which might explain why 90% of your ED sample were not in substance use treatment programs?
Yeah, so it's a great question. And the answer is absolutely, but that doesn't minimize their need. That if you are going to the emergency department over and over again, it may be because they need community services, but the very issue of reverse causation, you could flip around and say, well, that we have to see their attendance in the emergency department over and over again as a system failing them. And because the emergency department is not a great place to get addiction treatment. So reverse causation, I would say, is definitely an issue here, but I would expand it to say that is precisely the problem. And the very reason why we chose this cohort, because they have high needs, they're going to the emerge to get care. And how is it that to start understanding the linkage rate, and then, you know, the next step would say to think about responses. So to me, all the work that we do is kind of like a baseline against which interventions can be measured. So we you know, moving forward, if in the Toronto region we do make some effort to increase the connections, now we have data to monitor whether we're making traction in this reverse causation problem.
Thanks. And look, Paul, a question, perhaps the other panelists can comment on this as well. A theme between the incarceration session earlier today and the addiction session we've just had is this notion of people falling through the cracks and ending up inexpensive acute and tertiary services for brief periods, churning through those on multiple occasions, whether we're talking about prisons earlier today or EDs in your presentation. And that churn coupled with inadequate care coordination and continuity over time. And it seems like it's a bit kind of like Groundhog Day. We hear this over and over again, but it's evidently a difficult one to solve. From a translational perspective, what things have you done or do you think you might be able to do in your setting? I mean, for example, could you look at the cost of those frequent ED attendances and use that to make a business case for greater investment?
Was that for me?
Yes, or for any of the panelists.
Yeah. So, it's interesting. People often kind of freak out about emergency department visits, but the cost proposition of emergency department visit is not huge. So to me, I think of emerge as more case identification of need. But the corrections piece is an interesting one. And hospitalizations, recurrent hospitalizations for this stuff. I mean, it's very rare for somebody to get hospitalized for substance-related disorders. But Claire de Oliveira is just putting together a costing analysis of correctional data linked to our ICS data. I'm sure others have done it. But to me, the whole, it's Groundhog Day, but also I think the cost piece is really important for these kinds of populations because the presentations today were either like horrible outcomes or poor access or both. But when you overlay the cost, then you can say to policymakers, we're spending an enormous amount of money for the worst outcomes possible, and that is a true opportunity, right? That's what makes a policymaker sit up. They don't care about poor outcomes typically, but if they realize that they're spending lots of taxpayer dollars to get those poor outcomes, that gets their attention a little bit more than just the outcomes alone.
A bit of a lose-lose. Look, we have just over 2 minutes left. Do any of the speakers have any final comments they want to make or questions they'd like to quickly fire at each other?
I wouldn't mind adding to this conversation just around the point of stigmatization of people who use drugs for accessing services. And you can have, beautifully designed healthcare, but if people are not getting treated well and are not getting what they need when they go, people aren't going to use them. And I think there's also been a lot of work in British Columbia and particularly in Vancouver, which is really the epicenter of the opioid overdose crisis, is the use of peer navigators to help people through the system. And often it's something as simple as I just don't have bus fare, or it's too far of a walk and if you're injured, or you just don't know where to go. And I think there's a lot of simple things that can be done that make sense, that make people feel comfortable to access the services that are available. And I think those things can have a really big impact, coupled with like larger systemic change.
Thanks, Lindsay. And that's probably a really good note for us to end on. We are coming to the end of our session. So I just want to thank all of our speakers again. There's been a number of people commenting on how fantastic those presentations were. So well done to all of you. To let everyone know, the recordings of this session will be available on the conference platform in 48 hours time. And if you enjoyed this session, you might be interested in today's featured on-demand videos and posters, and you can find those in the on-demand gallery in the portal. Thank you very much, everyone who joined us again, and I hope you enjoy the rest of the conference.